I mean,
Yes, let us do that.
Imagica team, you can start up with the event. You can go live. Just give us a countdown of at least 5.
And I'll hand over to
Yes,
Dr. Manisha.
Yeah,
okay,
we'll
perfect.
hand over to you.
That's right, sir.
yes, sir.
So I'm just stopping my video and audio. Imagica team, you can give a final, 5 countdown. Imagica team, Trusha, Arti.
Yes, sir. Just a second, sir.
ম্যাম এবারে নেই, ওটাতে আপনার ম্যাম লিপস্টিকের কালারটা আসবে না, একটু ম্যাম
Give us a
ঠিক করে
final
Now
countdown 5.
start the session.
Also, you need to let me do screen share.
আর আমি লিখেছি মোবাইলে না
Yeah, that we will do.
লিপস্টিকটা বাজে আসে
হ্যাঁ,
আর আসতেই চায় না।
Yes, Amitabh sir. Now
उनका ही नेटवर्क खराब है.
Sir, we are live to the audience. Over to you, sir.
আমার
Okay.
মোবাইল লাল কালা এসেছে।
So, dear doctors,
হ্যাঁ ম্যাম এবার ঠিক আছে।
wishing all the inspiring ladies a very
না,
happy
একটু
Women's
স্মাইলি
Day.
বলে তারপর হেসে দিতে পারি, এটা কষ্ট হয়।
হ্যাঁ
ঠিক আছে
হ্যাঁ একবার হাসুন
Happy?
ম্যাম, কোনো অসুবিধা নেই।
Dr. Prathma, I would request you to, the mute your. So once again, dear doctor, wishing all the inspiring ladies a very, very happy Women's Day. I welcome you all for the discussion on a very, very important clinically relevant topic, which is the use of psychotropics in pregnancy and breastfeeding. Further, I welcome dignitaries of today's session, our moderator, Dr. Samiksha, speaker, Dr. Rukseda Saidat, panelist, Dr. Anita, Dr. Sasi, Dr. LG, Dr. Sonal, Dr. Khyati, and Dr. Prathma. Women mental health is a cornerstone of all well-being and fostering resilience, strength, and empowerment. Acknowledging and prioritizing the mental health not only enhances the individual lives, but also contributes to the collective progress of the society. By nurturing women's mental well-being, we pave the healthier way in communities where everyone has the opportunity to thrive emotionally and contribute to their unique strength to the world. We at Lupin understood the significance of the same in the Indian context and launched a unique campaign called Shila Plus, centered around women's mental health well-being. Shila Plus signifies the power of she in the empathizing and treating women and mental health challenges. We at Lupin truly understand this, and that's what this program is one of the very first step towards this. Today, once again, I wishing each one of you who are inspiring in one or other way to the society. Even in our culture say that wherever the women are taken care, women are respected, the devtas or the gods lives there. So we pay a lot of gratitude. We do appreciate your contribution at the professional and personal front. We do take a lot of inspiration from each one of you, and at the same time we also do pay a lot of gratitude. With this, I request Dr. Manisha to share a short glimpse of Share Plus that will set the tone for today's proceeding. Thank you.
Yeah.
Dr. Manisha, over to you.
Yeah. Thank you, Mr. Amitabh. Here, my voice is clear?
Yeah.
Okay, but a very good evening to all of you in this scientific session. I welcome you all and thank you for joining this scientific session with extensive discussion on behalf of Mind Next division team. My name is Dr. Manisha. I'm working as a medical lead of specialty group of Lupin Medical Affairs Division. I'm privileged to be part of this scientific session today. We have, in this program, we have very fantastic lineup of panelists who will be sharing their insights on this very important session today. So to start with, I would also like to give a brief about our Shila Plus initiative, which is a scientific platform, as Mr. Amitabh told us, that it is exclusive platform for discussion of women mental health, be it at any stage of their life. It may be mood, anxiety disorders, more common in women, but they are also affected by schizophrenic psychosis later in their life. So these various types of the disorders are being discussed on this platform with the help of our expert panel. So under Shila Plus, we encourage clinically relevant discussion to happen for the benefit of all. To give you a gist of the same, I will request Trisha to play a short video on the same. It will be a very brief video. Trisha?
yes, ma'am.
Yeah, thank you. Uh, thank you. Thank you all. So here we'll start the session. And before starting the session, let me give you a brief introduction for our moderator today, Dr. Samiksha Sahu. Dr. Samiksha is MD psychiatrist, gold medalist, a DNB, and fellow of child and adolescent mental health, and certified in the management of addictive disorders from NIMHANS, trained in CBT, BITS USA. Currently, Dr. Samiksha is assistant professor in Gandhi Medical College and consulting psychiatrist at BMPC. Recently, she has been elected chairperson of Indian Psychiatric Society Young Psychiatrist Subcommittee for the second time for the special expertise and experience in the field of psychiatry. She has been the energy behind the successful conduct of YPCon in Bhopal. And Dr. Samiksha holds special interest in child and adolescent psychiatry and women mental health. With this brief introduction, I will hand over the session to Dr. Samiksha. Ma'am, over to you now.
Thank you so much. A very warm and a happy Women's Day to all. Without further ado, let me welcome our renowned and special speaker, Dr. Rukshida Saida ma'am. Ma'am is a passionate psychiatrist, psychotherapist, and founder of Shrelis Family Center, Lokhandwala. She holds important positions as President-elect, Bombay Psychiatry Society, Vice President, Indian Association of Biological Psychiatry, Co-Chair, School Mental Health, IPS, and Committee Chair of Digital IPS West Zone Branch. She is advisor to Led by Foundation and Family's First Guidance Center. She is an author, media expert, TEDx speaker, a guide, and a teacher to me. Her passion project is Yami, a support group for young adults. Heartily welcome to Rukshida ma'am. It's an honor to have you among us. Now moving on to our panelists. I would like to welcome Dr. Shashi Rai ma'am. Ma'am is a consultant psychiatrist from Lucknow. She is currently the director of Sambal, Drug Addiction and Psychiatric Hospital. She is chairman of Richmond Fellowship Society, India. For her immense contribution over decades in the field of psychiatry, she has been recognized as Women of Substance Award by Hindustan Times of the year 2018. She has been honored by Minister of Health and Rural Development UP and received Baby City Oration Award for Central Zone. Ma'am, extending a very warm welcome to you, and it's an honor to have you among us. Next on, now I would like to invite Dr. Anita Gautam ma'am. So ma'am has been my advisor in the Young Psychiatry Committee and always there with her loving and sweet voice. Ma'am is the director of Child Clinical Operations and Consultant Psychiatric at Gotham Hospital at Jaipur. Ma'am is awarded with Dr. Inla Rama Subba Reddy IAPP Award 2012, City Icon Award 2016, Women Honor Award 2017, and she has various awards to her name. Ma'am has contributed a great deal to the society with her extensive work experience of 7 to 10 years and has participated and presented scientific research papers in many psychiatry conferences. Ma'am is also very active across a lot of news channels and she's always expressing her voice very clearly on very important issues. A warm welcome to you, ma'am. Moving on next, we have Dr. Elsie Oman. Ma'am is consultant psychiatrist from Medical Trust Hospital, Kochi. She has been instrumental in mental health education and training classes for the police force of the district, covering nearly 53 police stations. She also gave talks and classes in the media through satellite TV channels and YouTube channels, and through various organizations, including Kochi and Port Trust. During the COVID pandemic and lockdown, she was delivering messages through popular Malayalam channel on daily basis for 360 days. She's a regular debater in various Malayalam satellite channels regarding mental health issues. She is currently a member of Mental Health Review Board of the state. Welcome, ma'am. Next, we have Dr. Sonal Shukla. So, ma'am is currently working as a consultant psychiatrist in Manopchar, PG Institute of Behavioral Medical Science, and has a rich experience of more than 14 years. She is Life Fellow of IPS, member of APA, and represents various esteemed groups. Ma'am has a very brilliant sense of fashion, and she manages mental health with her own style. Next, we have Dr. Khyati Mithalia. Dr. Khyati is a consultant psychiatrist focusing mainly on women's mental health and child adolescent psychiatry. She is deeply involved in community work in psychosocial rehab of earthquake as well as riots victims. Her team has conducted several teacher training programs in Kutuch for identifying mentally disturbed children after earthquake. She loves to talk on mental health awareness in diverse areas like exam fears among students and parents, coping among adolescent girls, about sexuality, about peer pressure. Her interviews have been published and streamed in reputed national newspapers and TV channels. Welcome, ma'am. Last not the least, we have Dr. Prathama Chaudhary, ma'am. She's one of the leading psychiatrists of Kolkata. She's a professor in the West Bengal Medical Education Service and it attached to Fortis and Amri Hospital, Kolkata. She did her undergrad from Calcutta Medical College, her graduation from prestigious CIP and DN Rachi and DNB in Psychiatry. She did a WHO fellowship from New South Wales Institute of Psychiatry, Sydney, and a brief training at the UK College of Hypnotherapy. She's just not a doctor treating people in pain, but she believes in promoting positive mental health to all, for which she conducts a lot of workshops and contributes regularly to the popular media. We extend a warm welcome to you, ma'am. Now, not spending a lot of time, I would really like to appreciate Lupin's effort on this Shila Plus, the model which they have started, and this program being the pioneer, being the pilot on this thing. So, handing over the session to Rukshida, ma'am.
Thank you so much, Dr. Samiksha Sahu. Very well done. I think you're the youngest of us here today, and you've set the bar high for all of us to be enthusiastic and appreciative and warm and informative. So we shall try and endeavor and follow in your footsteps in that sense. Again, thank you to the organizers for having this discussion. I think it's always a very, very important discussion. And even though those of us who've been practicing and have been in the field, we now think that, oh, you know what, we know about this, we've learned about this, we've read about it, but trust me, there's so much more that so many of us still need to learn. And I'm happy to be the speaker for the simple reason that whatever I don't say or whatever I forget, the panelists are going to cover. So women always have each other's backs. And of course, we have Dr. Shashi Rai ma'am with a vast experience and the senior most amongst us. And of course, she's going to really, really see to it that we do a good job. And with Dr. Chaudhary ma'am with us as well. So I think we're looking at a very good session today. So thank you so much. And with further ado, I'm going to start sharing my slides. And I have warned Sarmishta to not let me speak for more than my allotted 15 minutes. Right. So I'm assuming everybody can see this and everybody can hear me. And thank you so much for that. And I am going to start with acknowledging Dr. Priyanka and Dr. Vaibhavi. They work with me on the monthly newsletter of Indian Association of Biological Psychiatry. So a lot of the slides are from them and, with discussions with them. They're the young brigade and they're really, really very inspiring and really know what they're talking about. So I have no fears if they're involved with this. And yes, a disclaimer that I do talk a lot, especially on this topic. So that's why Samiksha is the person. If I'm speaking more, that's her fault. So we're going to talk about prescriptions in perinatal period, isn't it? During pregnancy and during lactation. Why are we talking about this? Why is this such an important topic? Especially the last 1 decade, we've seen the number of prescriptions go up, number of psychiatric prescriptions go up in the perinatal phase. There are a lot of reasons for that to happen, of course. One is that because there's more awareness and there is more diagnosis of non-psychotic mental health disorders during the perinatal phase, isn't it? And that's great for us because more and more people are recognizing mental health and psychiatry, and the overall psychiatry literacy is improving. So while we understand that we are shifting away from use of any kind of substances, including medications, as much as possible during the perinatal perinatal phase, but because we also understand that there is an increase in prevalence of mental health disorders and psychiatric issues, there's also an uptick in the prescription. So now that more and more people are using prescriptions, we definitely want to be also sure that we know what we are doing, we know what we are dealing with, because far more women are aware, far more family members are aware, and they do definitely want a smooth pregnancy and the and the aftermath of it as well. We also know that we have so much more data now that suggests that untreated medical and untreated mental health disorders should be timely. If the mental health disorders are not treated timely, then there's no intervention, then the outcomes are going to be very severe to both the mother and the newborn, and of course then to the family. So there is a lot of evidence that suggests, that tells us that yes, definitely early diagnosis and intervention in women is going to be better for the child as well. So that's why I always say there's no mental health there's without women's mental health. So we understand, because the child can be at risk for a number of things. Hopefully we can talk about that a little bit more. Another one of the major reasons is that the clinical experience that psychotropics are effective drugs in treating several psychiatric conditions during gestation and breastfeeding. So we know that the efficacy of these medications have been proven time and time and again. So just as in general psychiatry and the larger group, the special group of women during the perinatal period is also something that we see that there is a marked difference, and there is an improvement in the symptoms, and of course then the functionality. So what are the adverse outcomes of untreated perinatal psychiatric disorders? When we look at depression is one of the most common symptoms common disorders that we see. Up to 25% of women in the US will have a prescription of antidepressants in their during their pregnancy, whether that was before started for a pre-existing condition or not, that's not, whichever way, but 25% of pregnant women are going to be on antidepressants just in the US. So if there's untreated maternal depression, there's intrauterine growth restriction, low birth weight, low APGAR score, significant increase of cortisol and catecholamine levels. So the birthing outcomes are also impacted because of untreated depression. That's the fetal adverse outcome, right? When we're talking about a severe depression and anxiety, we also know that there is a higher chance of a preterm delivery, and the admission to the NICU, the neonatal intensive care for the newborn is also the rates of it go higher. And of course, it also interferes with childhood development, because not only just that the child has been in utero exposed to this elevated levels of stress, but it also impacts the mothering. It also impacts the parenting of the woman, and that's why also it will impact the childhood development because of parenting issues. We also see in children with maternal severe depression and anxiety during perinatal phase that they have a higher impulsivity, they have more maladaptive social interactions, and cognitive, behavioral, and emotional difficulties have been observed in infants of these untreated mothers. When we're looking at mothers with high-risk health behavior, substance or illicit, substance or alcohol abuse and smoking, we definitely know that there is a higher chance of preeclampsia and, of course, gestational diabetes, along with the other previously mentioned adverse outcomes as well. When there is discontinuation of medications, we know that the chances of postpartum depression, psychosis, and suicidality increases multifold. So what happens during pregnancy, right? During pregnancy, a woman's body is going to change. That means by logic, we also understand that we also need to look at how the pharmacokinetics are changing, right? So there are, and these changes are going to be unavoidable. And this is going to be across all psychotropics. I mean, it's going to be across all medications. We're just going to focus on psychotropics today. And there is, it's difficult to clarify that what physiological changes of pregnancy and how that's going to impact the pharmacokinetics of medications, and then how are they going to affect them, right? Like we know that there is delayed gastric emptying and increased gastric pH, which might lead to altered drug bioavailability and delayed time of peak levels after oral administration of medications. We know that there is increased cardiac output. That means the increased hepatic blood flow, increased elimination for some certain drugs. We know that there is increased total body water and extra cellular fluid, and that means altered drug disposition, increased VD4 alpha for hydrophilic drugs. We know there is increased fat compartment in the women. So that means there's decreased elimination of lipid soluble drugs. There's again increased renal blood flow and glomerular filtration rate. That means increased renal clearance, decreased plasma albumin concentration, increased fat fraction of drug. So multiple physiological changes impacting pharmacokinetics really. So all that we know about pharmacokinetics and their functions and their efficacy and their outcome results, we do need to relook that in women who are pregnant and lactating. Having said that, it's not always very easy to have these kind of data and these studies, but we have so much more now in the last 1 decade than we did in the past. So how do we go ahead and select a psychotropic? So from a pharmacokinetic point of view, we need to understand that, okay, we want to reduce the fetal exposure. So that means a molecule with higher protein binding, smaller distribution volume, shorter half-life, and ideally good affinity with the efflux transporters. We want to avoid combination drugs. We want to avoid polypharmacy as much as possible, because the cytochrome is heavily modulated by pregnancy and interactions cannot be easily predicted. When we're looking at lactation, right, physiological changes of pregnancy, that is the increased plasma volume, decreased plasma proteins, increased renal functions, they're all going to revert to normal after delivery, which is a gradual process. And again, it will affect the drug concentration in postpartum period. That means the medications, the dosages, the timings, everything might then be required to change, not just because of a change in circumstances in terms of inability to sleep and long hours and rest and all of that, but also because of the physiological changes postpartum. A selection of psychotropics with, again, shorter half-life is important. Administration at a lowest effective dose is important, which can be very, very tricky in some of our cases. And the relative infant dose, the RID, needs to be below 10% when we are considering any molecule during breastfeeding period. Most of the molecules that we do use, the commonly used ones, the more safer drugs, definitely are below 10. But of course, again, there are some categories there. What we also probably, not everybody kind of recognizes, because, information kind of can get a little lost, that the previous categories that we would have of the A, B, C, D, X, where, no risk to relative risk, and, X being absolutely contraindicated. Since 2015, the FDA has shifted from that rule, that kind of category, to PLLR, which is the pregnancy and lactation labeling rule. Now, why did the shift happen? The shift happened because there was no clarity with the categories that we had before. It didn't address risk to mothers or to child. There was no mention of discontinuation of medication, how that will impact the psychiatric conditions. So the large category was also misinterpreted and misused very often. So the FDA believes now that the 5 narrative structure for pregnancy labeling is best able to capture and convey the potential risk of drug exposure based on animal and human data, or both. Also, that the FDA has determined that retaining the pregnancy categories is inconsistent with the need to accurately and consistently communicate differences in degrees of fetal risks. Therefore, the final rule is that the ABCDX is out of the picture, and we now follow the PLLR. So what is the PLLR? So these include subset categories that would be pregnancy, both during labor, including labor and delivery, throughout. So there's a pregnancy registry, exposure registry, risk summary, clinical considerations, and data. For lactation, the subset categories are risk summary, clinical considerations, and data, and females and males of reproductive potential, the pregnancy testing, contraception, and infertility. Now, this is something that we do follow, and that has made it so much more easier because previously, whenever there would be a suggestion of a prescription, a lot of people would come with, no, this is contraindicated, or this is category C. How can you say this is safe? It's not going to be harmful to the child, especially teratogenicity and all of that. I think the world is scarred with the thalidomide incident, and that makes everybody more and more cautious. Of course, so much so that we know that now a pregnant woman is more concerned. The pregnant woman is told to avoid even caffeine, let alone smoking and alcohol. So all of those things, and then we are telling them that you need to take medications. That can be very alarming. So frankly speaking, walking away from the ABCDX category pattern is a lot safer for us, is better for psychoeducation for a patient, and is better for us to reassure the patient as well as the caregivers why a particular medication might be required. So when we are looking at when do we prescribe, what do we prescribe, of course, we also always look at what stage the patient has presented in terms of preconception, pregnancy, or lactation, right? I mean, I don't know about other people here, but all of my patients who are in reproductive age group and may or may not be at risk for conceiving a child, whether they are partnered or not, I will tell them and I advise them and I prescribe folic acid because we also know that the recommendations are for taking a good healthy dose of folic acid or N-methyl folate for that matter 3 to 4 months before conception. We also consider contraception for at least 6 to 12 months after remission. So when people are, even in the general OPD, when women are coming and they're telling me they're going to get pregnant, and whether they may or may not have disclosed the information to the family, the husband and the family. So we do recommend that, do family planning, don't conceive for the first 6 to 7 months. Of course, that's also always important for the bonding of the couple, because spousal support is such an important factor in any kind of perinatal psychiatric disorders and their outcomes. And also, if at all possible, if there's been a single episode, we do try going off medications or giving a drug-free holiday trial, and then seeing if there's no emergence, then if of symptoms, then that would be great. Of course, in pregnancy, we will definitely encourage and counsel them for early, contact with the OBGY, definite antenatal access to antenatal services has to be encouraged. The anomaly scans have to be done so that they are also reassured that everything is going smoothly, so they can continue taking their medications. And of course, when we are, especially if somebody is on lithium and all of that, we definitely want to keep an eye on the cardiac risk, though which is not very, very significant, but because that's something that a lot of obstetricians would also be, and neonatologists will be concerned about. It's always better for us to keep an eye on that. And we definitely encourage that the childbirth should be in a hospital or a medical setup versus a home delivery, possibly. When there is lactation, we encourage exclusive breastfeeding on demand, no role for delaying breastfeeding to infants for 4 to 6 hours post medication dose. We were using that kind of method so that the half-life, trying to calculate the half-life of medications, but we now know that's not really necessary. And of course, we consider the RID, like I said previously, less than 10%. We do try and avoid telling people to breastfeed if they are on clozapine, and lithium also requires monitoring. So in certain cases, we may advise them that they may consider not breastfeeding the child. And of course, adequate sensory motor stimulation and emotional care of infant is encouraged. So the mother-child baby unit really does come into the play. We also involve the other caregivers, whether they are from the mother's natal family or from the with the partner, the husband, or the in-laws, whoever is more involved with the child, the raising of the child in infancy. That's something that we definitely want to encourage their participation as well. If a patient is a woman is already on medications and is planning a pregnancy or is already pregnant, we definitely want to keep into mind that psychoeducation, psychotherapy, medications with the most safety data, uh, all of those things are definitely something that we want to keep in mind while prescribing, whether we're talking about antidepressants, anti-anxieties, mood stabilizers, antipsychotics, or even anti-epileptics for that matter. If the patient is already on medications, we do definitely want to try, and even if they are on polypharmacy, try and reduce it to a monotherapy as much as possible. We definitely also don't want to risk reducing medications too quickly or too much, because the symptoms and the dysfunctionality of the brain is more important to be treated than the risk of medications that may or may not be present. This particular slide is the image is from a wonderful article by Dr. Prabhachandra, Indumati, and Bhardwaj that's published in our Indian Journal of Psychiatry. So that's actually a very, very good article, and the reference is given here. So if some of us who haven't read that article already, I highly recommend that you go ahead and do that. Also, because of this next slide from the same article, that the choice of treatment is what is most effective for the woman is what is our number one priority. Switching to ineffective psychotropic medication may risk more harm to the mother and the infant. Advising a mother to stop her psychotropic medication may have significant adverse effects for her and the child. Routine fetal morphology scans and are supported to complete routine antenatal care. Women with mental health issues may use alcohol, so a particular consideration for that. And women with mental illnesses have a birth plan, having a birth plan prepared by the team supporting with her mental health is also very important. So as the slide suggests, and as it's so pictorially, so easily depicted here, that the risk of relapse of illness and pregnancy is higher even on medications, and we see that quite often, and that can be very scary and very fear, for the patient as well as the family. And we also know that risk of cardiac defects in newborn is practically the same, whether they're on whether the mother is on treatment with SSRIs or no. Of course, there are the meta-analysis and everything explaining this low risk or association with cardiac issues is. I'm happy to share that material later with anybody. So in the end, again, all women of childbearing age who are receiving psychotropic medication must be sensitized about risks and benefits of medications. The better informed the woman is, the less anxious the person is, and they are more empowered to make their decisions. And we definitely want to improve remove that agency that most women may not have. Only if the woman does not have the capacity to decide, the nominated caregiver or family or partner should be involved in the decision-making process. The risks may be present in terms of relative risk. It's very important for us to say that it is a relative risk. It's not a absolute risk, and it's an association. It's not a causation. Those are words that we definitely can start using with our patients, and they do understand. Document all your discussions of the questions they had, the explanations you gave, and the decisions that were made. And of course, with informed consent, it's always, it's always better, not just because we want to safeguard ourselves, but we also want to keep the history ready in case, even during the second pregnancy or the subsequent pregnancies, or OBGYN might want it, a pediatrician might want it, because we do definitely ask the birth history of a child when we're looking at other neurodevelopmental issues in them. So again, at the end of the day, the take-home messages are mental illness in pregnancy is associated with increased rates of pregnancy complications. The perinatal period is high-risk time for mental illness to develop or deteriorate, and postnatal depression is associated with poor maternal-infant attachment and poorer long-term development outcomes for the child for as long as 25 years of age of that offspring. So thank you so much for a patient listening. I hope that I've covered some amount of topics that are relevant to the discussion, but I am also very, very confident that the panel coming behind me is going to share so much more from their clinical experience and clinical pearls, and maybe dive a little bit more into the details of prescriptions of in perinatal psychiatry. Thank you so much. And if I have overshot my time, I apologize again, but again, it's all Samiksha's fault.
No, ma'am, it was well within time. Thank you for your beautiful pink slide. It is just in the zeal of Women's Day, and we really love the GIF which you have, looking so much like you. So moving on to the panel discussion. So first question I would like to ask Dr. Shashi Rai, ma'am. Ma'am, with your permission, should I begin?
Sure.
Ma'am, okay. Yes. So the few initial 2-3 questions are going to be case-based, and then there are going to be some general questions. So the case is there's a young female who is diagnosed with bipolar disorder and was on prophylactic lithium for past 2 years. In the second trimester, however, she stopped her lithium, and she came to the clinic after stopping the lithium from past 10 days. So in your clinical experience, what should be the clinical approach in these kind of patients and scenarios?
See, it's very common that such patients stop the medication as soon as they come to know that they are pregnant. So considering she has already stopped lithium, then we should not continue that as per se, and try to manage her on the atypical antipsychotics on a low dose if she's managed. I mean, what is her clinical presentation right now? Depending
She's
on
coming.
Is she maintained, or is she having florid symptoms? It will depend on that. So suppose she is maintained, she is not very aggressive, and then her lifestyle changes, decision can be taken to so that she has proper sleep. Lithium should remain stopped as such, and we start with a low dose of atypical antipsychotic and see if she's managed. And I think she would be covered. And suppose there is sleep issues, then the Z drugs, the Zolfresh, we can start with 5 milligram, or melatonin can be given, and she can be managed. So I don't think in this case mood stabilizer should be started again.
So
They should
as
be
she
kept.
was,
Yeah.
all right, ma'am. So as she was already taking till the second trimester, is there any additional investigation or any precaution or any other OBGYN consultation, anything should be given to her?
She should definitely go for ultrasound scanning.
Okay.
Because the second trimester, so she should go for that.
Okay, ma'am. Any role of folic acid in like how Rukshida ma'am also mentioned, should we be emphasizing more on it, ma'am, during this time?
Folic acid should be given. I mean, folic acid, as Dr. Rukshida had very rightly said, that it should be started at least 1 to 2 months before conception, and it should be continue even after delivery for 3 to 4 months. So if she's not been on that, because you suppose the patient has come to us in second trimester and she's already going to a gynecologist, then we have to see her prescription, what she's getting, because most probably should be getting folic acid. But if she's not getting, then definitely we should add.
Okay. Another part to it, if by chance the patient is after stopping the medication and she's representing some depressive features or maybe some anxiety or depression is starting, then what should be our approach, ma'am?
See, suppose she is having, like if it's a bipolar patient and if she is having depressive features, then we can start with the low dose antidepressants can be given, or even lamotrigine is supposed to be very safe in pregnancy. So we can give that and with a start with a very low dose. And if she's having no problem with the drug per se, then it can be given. As far as the anxiety is concerned, for a short period, we can give her the etizolam group of drugs. But definitely we should try to avoid the benzodiazepines.
Thank you, ma'am. Moving on to the next question, I have Dr. Anita, ma'am. Can I ask? Anita, ma'am? Ma'am is mute. Hello?
She is muted.
All right. Okay. I'll come back to ma'am again. If somebody from the team can contact ma'am, I think she's not able to unmute. All right. Now moving on to the next question. Dr. Elsie, ma'am, can I go ahead?
Yes, sure.
Okay. So clinicians, they're often apprehensive about treating pregnant and lactating women as the information on safety of psychotropics is either inconclusive or undetermined. So what are the clinical guidelines and recommendations about the usage of psychotropics drugs in pregnancy and lactation? Does it have more clarity in terms of actual clinical practice in Indian settings?
See, it depends upon, like Dr. Ruksha has already mentioned, it depends upon the risk versus benefit. We have to see in our settings, usually we see patients with infertility for nearly somewhere around 15 to 20 years. So they'll be having severe depression. So they, probably they'll be going for IVF treatment. So, they have their own risk in having a pregnancy and also having a healthy baby also considering the age, because already they have crossed 35 plus or maybe 40 plus. So that risk is there already. And along with that, see what if such cases are coming, what I tell my patients is, see, if you start an antidepressant, then chances of pregnancy is also very high. This is from my clinical experience also, because they'll be taking treatment for many years for this infertility issues. And because of the depression aspect, the rate of fertility will be less. So once if we are able to handle the depression, once we are able to remove the depression from such candidates, then having the success rate of the pregnancy is also very high. So then again, considering the risk, see, maybe up to 10%. That is what the researchers are showing. So that 10% anyways, or more than that, they are taking considering their age. So in such scenarios, instead of focusing on the minimal side effects of our drugs, rather than focusing on that and avoiding that and being depressed and getting the success rate to the lowest side, it's always better to motivate them to take medicines and get rid of the depression and have a pregnancy rate to the higher side. And what again we have to ask them is to have a regular checkup, then including the ultrasound and taking the help from the gynecologist also. And always we have to document that this risk is there and we have to get the consent and get their signature. And if we start, then I think that is the best thing we can do for people who are having depression or any other mental illness during pregnancy. And coming to the lactation, see, we have to consider the bonding with the child, bonding with the baby. So again, she very clearly, she mentioned how to go about it. So I'm not going to repeat all those things. But if in case, if we find that there is a risk of having side effects in the baby, then definitely advise them to avoid that and go for substitutions.
because breastfeeding is needed for the babies, but still, if there is a risk of side effects, babies, if they are demonstrating, for example, excessive sleepiness or being very silent or activity is very poor. In such case, then we can advise them to stop breastfeeding and go for a supplement or go for a substitution. And mental health, again, here is very important. Just to promote breastfeeding, and if you are asking the medicines to be stopped, then what will happen is the lady won't be having a good mental health to have a bonding with the child. The lady won't be able to take care of the child, take care of the baby. So in every scenarios, what you have to do is we have to weigh the risk and the benefit, and if little advantages when we give medicines, then go for it.
Okay. Thank you, ma'am. Moving on to the next question, I have with the Dr. Chaudhary, ma'am. Ma'am, can I take the question?
Yes, can you hear me?
Yes, I can, ma'am. So a young female presents with a history of recurrent depressive disorder and has been taking antidepressants. Her UPT comes out to be positive, and she has been reporting that she's having decreased sleeps and she's feeling very anxious about the effects on the infant. So what would be the appropriate advice for discontinuation?
See, like for example, I wouldn't really agree with the term discontinuation, because I'll give her the pros and cons. I'll tell her that she has had recurrent depressive episodes. I believe now she's euthymic. Now she wants to stop because both she and her family feel that they should have a organic pregnancy, kind of, no exposure. But I will, first of all, I'll tell them that having another depressive episode itself amounts to an exposure. So if you have, let's say we stop it, we discontinue, and then you have the chances of relapse are much more. They say that even if you are on antidepressants and you are having RDD, then the chance of relapse is, let's say, to the tune of 26%. On the other hand, if you stop your prophylactic medicines, whatever they are, then the chances of relapse just jump to 68%, which is much more. And what happens, Dr. Ruksheda has already said that if you get into pregnancy and then develop depression, so much can happen to your child. The chances of preterm delivery increases. There is also, if you have depression, it doesn't happen in the air. No? There is a sustained increased cortisol levels. So that may bring about epigenetic modification of the glucocorticoid receptors in the brain. That itself may cause later on severe mental illnesses. Chances of having even cardiovascular events become more for the child. So first of all, I'll sit with the woman and her family to say that it won't really, I'll inform them. It's of course a question of informed decision. So if they still, I hope I'll be able to convince them that continue with the antidepressant. Now, which antidepressant? So there's a lot of theory about it. Some people say that paroxetine is more teratogenic and cardiovascular and all those things. But as of now, I think most meta-analysis tell us that she's well controlled on a particular antidepressant. Let her continue with that in the same dose, because why unnecessarily create a chance of relapse? Now, supposing she's on RDD, she's having RDD and she's on lithium. Then again, the question comes, should we continue on lithium and all that? So that there we have to talk more about it, but that's one. Another mistake that we often make is say that first trimester band kar do, because the first trimester is important organs are formed. But here I would like to share that the majority of a lot of relapses happen in the first trimester itself. So that won't really be a good idea कि आप first trimester में हर medicine बंद कर दो and then you start again in the second trimester when the organs are already formed. So that will not be a good advice for us to give. Having said all that, telling her that it's better to continue on the same medicine, same dose, no point stopping and all that. If she still wants to discontinue, then of course it's her informed choice, we call it. So in that case, I think what I'll do is I'll try to taper off, but put her on intense psychotherapy. At least she remains under the scanner. We know what's happening with her. We give her the supportive therapy that's required, but that will be my second choice. I'll try my best to convince her. Don't expose yourself to another depressive episode. That's how I'll go about
another part to this question I would want to ask, ma'am. What is your advice on the role of neuromodulation, like RTMS, if the patient is unwilling for medication? Nowadays, people read up, they come with the choices, like, I want to get treated by this. So, what is your recommendation or your take on that? Like, can
See,
you
like
switch
you
from
were in a scenario saying that this woman who's suffering from recurrent depressive disorder, at the moment she's symptomatic and pregnant. She's both having symptoms of depression and she's pregnant, and she's telling us, please stop and put me on something alternative. Like I'll tell again, why disrupt the equilibrium if you're already well controlled? Then I'll not encourage RTMS or alternative methods. But if she, let's say she's on escitalopram and she's still having significant symptoms of depression, and she's asking for alternative methods instead of another medication, then the pros and cons, Uksheda, you will correct me if I'm wrong, then the pros and cons will be weighed. But as of now, I don't think we have enough data. We need more data, more and more data. I mean, there is data about ECT in pregnancy, forget that. But RTMS in pregnancy, tell me, I think there isn't enough data to say that go for it. Can you tell me, like anybody, any of the panelists or any one of the speaker, RTMS, how much data do we have in, let's say, in pregnancy? And somebody who's not controlled. If she is well controlled, I'll say no. But she's not controlled, and instead of shifting to another medicine, she wants RTMS. That's a very interesting scenario. I think we don't have enough data, but I would like to know more from the other panelists.
No, even I feel if the patient is not maintained and we don't have data on the RTMS, so she should continue on her medication instead of going for a new thing about which we don't have any robust data that to say that it helps or it does not help. So it's more important for her to be maintained.
Yeah. Do we have data on RTMS as of now? Enough data?
We don't have, ma'am, enough data.
Only studies are going on. There's no robust data.
But there are ethical considerations when we're talking about studies on women who are pregnant and or lactating, isn't it? So to get that kind of data is not very easy. There are some case studies and there are some short, small studies done. But again, we don't have enough information in terms of not only just the efficacy of the treatment, but even in general population, but also the safety profile in pregnancy.
Absolutely. That's why we have to go slow, because the data collection would also be difficult, and we can try it only on somebody who's not responding to medication. Otherwise, then we can try, and that there comes the ethics part. And so maybe because of that, we are still slow in gathering data. Somebody will be able to answer this question more effectively.
And from a medical perspective, just because somatic therapies, especially either neurofeedback or RTMS and all of that, they're not first line of treatment. So to be able to kind of like say that, yes, I recommend RTMS as first line of treatment would be rather exposing ourselves to liabilities. So I would suggest that maybe not a space we want to enter very easily.
Because we are not just clinicians, we're educators as well. So many times patients come and tell us, why don't you try this? So it's our job to tell them, see, this is the cafeteria choice kind of, these are the pros, these are the cons, and then gently guide them. We call it a nudge, if not a push. So you nudge them towards the right direction. That's
okay. Anita ma'am, do we have you? All right. Moving on to the next, thank you, ma'am, for this. Now, moving on to the next question from Dr. Khyati. Can I ask, ma'am, can I go ahead?
Yes. Yes, am I audible?
If you can speak up loudly, ma'am, the voice is in the lower side of the volume.
Yeah, so now?
Yeah, better.
Is it okay?
Okay.
Yeah.
Much better, ma'am. So my question is, what is the role of mental health support system in patients during pregnancy and lactation? And what is the importance of taking informed decision about continuation of treatment according to patient's expectation and preferences?
Okay, so talking of the first part, the role of...
Kathy, you're on mute again.
Yeah.
I think I got a call. Yeah, so now am I audible?
Better.
Yeah.
Yes, ma'am.
So role of mental health support system it would comprise of, I think, both the things, that is the mental health professionals plus the mental health support from the family, friends, etc. Right? I think that's what you are meaning, both. So as far as the mental health professional is concerned, whether the patient is on treatment or off treatment, the mental health support is definitely needed. As Dr. Rukshida said, that even if the patient is on medications, on psychotropic medications, still there is a chance of relapse or increase in the symptoms because of so many, you can say, physiological factors as well as psychosocial factors. Pregnancy in itself is a stress. There are so many new adjustments, new things which with which the lady has to, our patient has to cope up with. In that phase, she might be having so many questions, doubts, problems with her family, their expectations not being able to meet with that. So in that case, if she is talking about her concerns with her friends or say partner, her family, and if they are supporting her, that is going to be very good for her. And to, like, in some extent, when that does not help, then talking 1:1 with the therapist can be a great way to manage the stress, deal with her depression, ease anxiety during pregnancy. Like CBT, IPT, both can help managing her negative thoughts, changing the way she is thinking. In IPT, it helps, we can help her identify and deal with her problems with her family, especially in Indian setting, joint family. One thing which I would like to add, which is not written anywhere, nor we were taught, but in Indian settings, still there are girls, patients who are living in joint family and they are not having their own assertive way of living. They are still doing or following what the in-laws are saying. In such cases, I talk to the husband and the in-laws separately and give the psychoeducation of being good with her, being warm with her, taking care of her. And if I find that if some people are just insensitive, I may even frighten them that, see, if the depression is going to increase, it is going to be a problem for the baby as well. That is like signal which everybody picks up and they start behaving nicely with her if there is a problem in the environment. That's it. Yeah, and your second question, can you just repeat that?
Ma'am, about the consent, like many of the previous speakers have spoken about the term consent. What will be your take on that? Like, what is the importance of taking informed decision about continuation of treatment according to patient's expectation and preferences?
Yeah, so when you say the term informed consent, it becomes more of like documentation, like what Dr. Rukshida already said, that explaining the pros and cons, everything, documenting that we have explained, and then we ask the patient what she wants, maybe the relatives also what they want, and we do that. So that is the, you can say, technical part. Now, clinically, when we do that, what I say, see, like Dr. Guha ma'am also what she said, that in the first trimester also she wouldn't prefer discontinuing the medicine for the risk of relapse of depression. What I do is in the first trimester, I explain them about the potential risk, you can say teratogenicity, organogenesis is there, and there might be some, you can say, malformation or something. But then I also talk about the percentage, that it is only in this 2 to 4% or something. So what you need to, what you want to do, that is, I tell them very clearly. Then I also give them the examples of the patients who have been on medicines and they have been fine. They have been really fine because depression was under control and there has been nothing to the baby. But still, I wouldn't take a risk looking to the legal, like medical legal aspects, because if we say that only 1% or 2% patients have the chances, but by chance, if that patient falls under that 1%, then for that patient, the 1% statistics does not hold true. If only I am there and my child is deformed, having some malformation, then I'm going to not like it and nobody will, in fact. So I really leave it up to the patient. But from second trimester, I do encourage that use of medicines.
Thank you, ma'am. Now moving on. So
We-
then, ma'am, I have yes,
we,
ma'am. Do you?
we do know that, there is an escalation of symptoms between 35 to 38 months of pregnancy, but we don't know why that escalation in symptoms happen, because a lot of the times people may go off medications or reduce it or change this, or so we don't have enough clarity in terms of when the symptoms might start. And just like Kathy said, that the relative risk is something that we need to talk about. And frankly, when you're being honest and you have a rapport of trust built with the patient as well as the family, and when you're speaking to them and saying that we can't say for a fact whether this would be because of the medications or this was supposed to happen anyway. So frankly, Indian population is also very, very good about because we're very fatalistic and we believe in God and all of that, so it becomes easier for them to accept. And Kathy, just a few weeks ago I was in Ahmedabad doing a community workshop, and there was one session was for men, and I talked about spousal support during perinatal phase, and that was so well received, and they were so happy to even hear that. It was very encouraging for me to see men understanding and getting that as in a group, because when we're talking about one-on-one clinical settings and we have that rapport, of course when you emphasize spousal support, we do see that shift in not only the attitude towards the woman and mental health, but also positively towards medications. And that does make a lot of difference, not only in terms of the relationship between the couple, but also it extends to the larger family, because most of us live with either at least a set of in-laws, if not the entire joint family. So yeah, so talking to the men is really, really beneficial.
See,
I'll
one point I would like to make regarding this mental health support, that most of the patients, when it comes to child or the infant, they take the word of the gynecologist much more than the psychiatrist at this. And as soon as they go to the gynecologist, they say that stop the medication. Otherwise, I will not take the responsibility. So that issue also has to be really taken care of, because then in that case, they believe them more. That is one thing. And second, usually by the time the lady comes, most of the times it is the first trimester has already, it's nearing over. So we should definitely advise them to continue, because some gynecologists say that get it in return, that the medication is not good. So that issue also has to be dealt, because that will keep, haunting the patient. That is it.
Thank you, ma'am. So Dr. Sonal, ma'am, I have a question to you. How to tackle the aggravation of psychiatric disorders during the pregnancy phase?
This question was for Dr. Sonal.
Yeah, if it was for you, am I audible?
Yes, ma'am. The question is
yes.
to Sonal, ma'am.
She said if it was for her, then she can answer, no problem.
No,
You can ask another one, no problem.
No.
No.
Okay.
Acha. So the question was how to, yeah. Can you please, Samiksha, thank you so much for inviting and asking question. So yeah, sorry,
I will
this
repeat.
aggravation part, na?
Yeah.
Yes.
Yes, ma'am.
Yes, sir.
So how to tackle the aggravation of psychiatric disorders during the pregnancy phase, be it a
Right.
depressive aggravation or a psychotic phase which is getting aggravated. So what is your take on that, ma'am?
So you want to say that the patient is already on like medication and that pregnancy has aggravated the symptoms, right?
Yes.
Yes, whether it is depression or schizophrenia or bipolarity or whatever. So the point is ki like she is already on medication, and the thing is ki usually first few everybody agree, as Rukshita has mentioned, I think everything. So thank you so much, Rukshita. And I would say like ki first 3 months the patient is, as she said already, more prone to aggravation and all. So close check on the symptoms emotional and mental and physical well-being of the lady and support. We have actually, it's both, it has both pros and cons, like the society, the in-laws, the supporting in-laws, and which is very, like, actually it is decreasing as the nuclear family has become more evident nowadays. So husband support, of course, early sign and symptoms. If they, we should actually explain them the depressive, they like check for her irritability part, her sleeping part, her pattern. Like they usually are very observant, because they have already seen her in that phase. They become very observant and very close and monitoring the early sign that he will come with the lady, walk in through and say there's some change, ma'am. She is very silent nowadays. So, educating them regarding more and more, or regarding the symptom, early symptom. And if required, psychotherapy, group, I think, yeah, as she rightly mentioned, that in-laws separately talking to them. And because sometimes she becomes completely cut off with and restrict herself to a room, which is very dangerous, because, sometimes even they plan suicide in that phase. So, yeah, there should be somebody around the lady, who are like, nutritious food, proper diet, proper timing of medication, somebody around to speak to her. So yeah, I think I answered most of your queries,
Yes,
and if
ma'am.
something, yeah.
All right.
Yeah.
So moving on, ma'am, one question I have with Dr. Shashi Rai, ma'am. Ma'am, can I go ahead?
Yeah, sure.
Okay. So there is this 30-year-old patient diagnosed with schizophrenia who is on depot flupentixol 40 mg fortnightly, and she has just found out that she's 6 weeks pregnant. So what will be the correct advice to give her?
So because she's already on that medication and if she's maintained well, but ideally speaking, depot preparation should not be given in pregnancy. So like the dose which she has taken, that's fine. But for subsequent, for further this one, we should put her on a low dose oral medication because that is not advisable to give a depot preparation. That is it.
Okay, ma'am. All right. So we'll go ahead with the questions. We have received lot of questions in the
Yeah,
chat. So should we go ahead with that, ma'am?
sure.
Dr. Meghna, you'll be taking those questions, or should I go ahead? All right. By that time they answer, I'm going to ask the question. So Dr. Suman S. Rao from Bangalore asks, what kind of monitoring is recommended for pregnant or breastfeeding mothers taking psychotropic medications and for their babies?
Whom do you want to answer that question?
Anybody can answer. Rukshita ma'am, you answer.
से free for all करोगे तो chaos हो जाएगा. So when I'm assuming they're asking lab monitoring and things like that, isn't it? So when we are looking at any particular person, especially when we're looking at a pregnant woman, we're going to look at various parameters in terms of the usual blood work that we might do for all kinds of infectious as well as metabolic disorders, blood pressure, and depending on what it might be, even ECG and 2D echo and things like that, which again, if there is an gestational diabetes or hypertension, definitely that also the monitoring needs to continue for that. When we're looking at the child, the fetus in utero, we are definitely looking at anomaly scans. If you're asking anything particular we need to look at because the woman is on psychotropics, not necessarily, along with the usual precautions that we would take in terms of, if it's a antipsychotic, we might definitely just keep an eye on the metabolic profile, maybe definitely emphasize on healthy lifestyle, especially postpartum, encourage the other family members or the spouse to take over the child care duties a little bit more so that there is some amount of sleep that the mother might receive, because that's one of the most therapeutic things that we can encourage them to do. And like Dr. Sonal said, social isolation is is something that's very, very threatening and can be very difficult. So we definitely want to monitor social interactions as well, not only in terms of the social interactions, like she said, isolation, but also the social interactions, the other people, what kind of gyan are they giving her? Because that again, when we're talking about postpartum phase, the hypervigilance may be increased because of either a pre-existing mental health condition or just during the perinatal phase, and the misinterpretation of social cues can also be present, and that might feel threatening to the new mother and things like that. So when we're looking at monitoring, we don't really need to monitor anything different specifically and there's no risk really in terms of anything. And of course, we're the usual with the clozapine and lithium, we would definitely monitor different parameters. But as we suggested, that those might be something that we might consider reducing to a more effective, the least amount of effective dose. And the usual monitoring that we would require for any general population also applies to this special category. I hope that answers your question.
Yes, ma'am. One more thing I would like to add, like a lot of people, those who are on a long-term SSRI, escitalopram and such, they often change the clotting time and bleeding time. So many times when we get the call for these patients, we often ask them to get a BTCT and coagulation profile done. So just to maintain the bleeding time. So if they're planning a cesarean section, they can arrange extra blood and all those sort of things. Just my take on that.
So usually the so-called adverse effects or, of SSRI pre-pregnancy, during pregnancy, we don't see a lot of change. So if the bleeding time, clotting time really hasn't really impacted pre-pregnancy, it might not really make a lot of difference during pregnancy. And the risk of increased bleeding during delivery and everything, which was considered significant previously, now we know that it's not as significant. And again, it goes back to maternal health and that decides the outcome. But yes, definitely. Thank you so much, Samiksha, for correcting my oversight that those are parameters we definitely want to look into.
Thank you, ma'am. Next question will be to Dr. Khyati from Dr. Zoya Nakhat from Bangalore. First of all, she's really appreciated Rukshida ma'am and all the panelists for the lovely session. She wants to ask, are there specific psychotropic medications that are considered safer during pregnancy and breastfeeding? Can you provide some examples?
Yeah, usually on the antidepressant, anti-anxiety side, sertraline I prefer, that is the safest during lactation as well and during pregnancy. Besides that, escitalopram, as you said, paroxetine, there are some it is doubtful, but sertraline and escitalopram are safe, and I prefer that. During lactation period, among the antipsychotics, risperidone, olanzapine, we prefer. I think even during the pregnancy phase, trifluoperathine, risperidone, we prefer. They are relatively safer as compared to other. And in mood stabilizers, lamotrigine would be the safest, I would say. And I think experts can add to their experiences.
So to add to this, during lactation, drugs like olanzapine, quetiapine, which have less of placental exposure, they are considerably very safe. And one thing we should take care is a drug which is safe in both the phases, in the pregnancy plus lactation. If that is given since the beginning, that will be more appropriate because then we'll not have to change the drug.
Okay. Dr. Rukshida ma'am, there's a question directly to you from Dr. Reena Sharma from Ahmedabad. Could you elaborate on how the new pregnancy and lactation labeling rule, PLLR, improves the communication of risk associated with the use of psychotropics during pregnancy and breastfeeding compared to the old letter category system?
So I thank you so much, Dr. Sharma, for that question. Because the PLLR, what it does is it's a more comprehensive approach, right? It's more evidence-based, and of course, the ABCDX was from 1979, and that was just continuing. So we had less information before. We even, in fact, didn't even have SSRIs during that time when this was started. So definitely, the PLLR system is better for because it's non-threatening in a way as well, right? And we are definitely talking about SSRIs in general also, and not particularly in women, because it helps us to make more individualized treatment and speaking to the woman as well as the family from a point of view from that person, and not just from a category. That so we're in a way humanizing the treatment as such, that for you, these are your symptoms, these are the medications you're responding to, these are the relative risks that we may or may not see. If we see this is what we will do, and this is what we will not do. If there are no risks, then we don't need to worry about it. And when we talk about associations and not causations, we are giving more information pertinent to the person, and not talking from just a broad category of without taking into consideration the particular patient's requirements and needs. I'm not sure.
Ma'am, you froze. Rushida ma'am, I think your screen has frozen. All right, we'll ask ma'am to comment on that again. Next question is to Dr. Chaudhary ma'am. Ma'am, this question is from Dr. Sayanta Nayak from Dibrugarh. He wants to know, could you explain how the risk of psychotropic medication exposure to the fetus or infant are weighed against the benefit of mother's mental health?
Can you just repeat the question?
Yeah. Could you explain how the risk of psychotropics medication exposure to the fetus are weighed against the benefit of mother's mental health? So it's like, whom do you want to choose?
Okay, that's an important question. The child and not the mother. But we tend to forget that if the mother is not doing well, both during pregnancy and after, it doesn't augur well for the child also. We've already discussed that an untreated mental illness during pregnancy increase the chances of low birth weight, preterm babies, a fearful temperament, even a drop in IQ, and also further chances. And we have also discussed how raised cortisols can bring about modifications in the glucocorticoid genes and make them more vulnerable for early cardiovascular symptoms. In addition, imagine a mother who is depressed soon after pregnancy. She's an absent mother, so there is the attachment bond does not. So I think for all practical purposes, what is good for the mother is also good for the baby. So this thing we have to always keep in mind. Otherwise, what happens? This confusion remains forever. There are certain exceptions. Of course, we will try to avoid valproate because of the neurotube defects. Lithium, the mother is doing well on lithium. There's just no reason. We have to talk about Epstein's anomaly and all that. We can try other atypical antipsychotics, but if she remains uniquely responsive, then also we might consider that itself. So, like I said, Kije, we have to explain to them that you possibly, if the mother is, we keep on pressurizing the mother, up thoda sahan lo, you deal with your depression and then don't take medicines. It will be good for the baby. Answer is, with all due respect, no. If she's asked to overstrain and if she is made to feel guilty, then that actually doesn't translate into good something good for the baby as well. So this is something we have to remember. Like the basic thing, all obstetricians follow, that if both the mother and the child are at risk, they look after the mother's safety first. But with us, we are not so much of a dilemma as well. We will think about the mother, but while we think about the mother, we actually think about the baby's good, I think. So that way, I hope the question is answered. This is how we have to talk to the patient's relatives and the patient herself to allay her guilt. That's my submission.
Very well answered, ma'am.
Thank you.
Do we have more questions, team from Lupin?
No, no, ma'am. I have this one.
No,
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 ma'am.
ma'am.
All right. This is one more left in the chat box. Quickly, we'll sweep through this. Sonal ma'am, I have this question for you. It is from Mr. Abhishek Saxena. So, what are the potential risks and benefits of using psychotropics during pregnancy?
I think this question was like just now answered. So yeah, so risk and benefits, of course, we have to explain to the patients and the caregiver. Abhishek has asked this question, right? So yeah, it's a good question, but risk and benefit always like nothing outweighs anything, I guess. A healthy mother, healthy baby is our priority, of course, but not at the risk of, discontinuing abruptly all the antipsychotics or antidepressant, I guess. And anyways, if she's maintained on minimal effective doses, there is no point in that. Suddenly discontinuing the thing and aggravating the symptom and then keeping admission like with a 2-year-old, 2 days also we have kept, we have to keep them separately also sometimes. So it is traumatic to whole of the family. So of course, if she's already maintained most of the time, they don't inform us, then abruptly withdraw everything, then she becomes full-fledged blown again, acute and transient phase, very difficult to manage. So better to explain them like, no, please inform us, please let us know if she's even planning to get pregnant. Don't discontinue the thing. Don't give her a medication if you in hand. Of course, उनको हाथ में नहीं देना. Of course, आपको लग रहा है कि she might overdose itself the drug sometimes, So yeah, so the benefit of healthy mother and healthy baby should always be the priority. Yeah, I hope I answered.
Yes, ma'am.
Thanks.
Okay. Is there any so I would just like to say one thing. Like it is said that every minute there are almost 34 children are getting delivered every minute in our country.
Yes.
And mental health is very, very prevalent. It is something which is there in our genes. It is going to pass on to generation. And the WHO states that out of 8 people, one is suffering from mental health problem. So we need to understand that mental health problems are there. It is not something which is happening in your neighbor's house. And discontinuing medication is not the solution. What is the best solution which we have understood out of the discussion is continue whatever the medication is that person on. If there is a discontinuation, select the least, select the dosage, with the least effective, minimally, which the dose which will cause minimal side effect, which is safest during the pregnancy. You start on that. Provide the female with maximum support, be it physical comfort, providing her emotional comfort, providing her the comfort of the psychiatrist. Try to collaborate with the OBGY. You can talk to your psychiatrist or your OBGY to have a discussion among themselves. And it will be a special request if you have any OBGY joined us today because they have shared it on the public platforms that please don't be scared of the psychotropics. They are important. Please don't scare our patients because if they will relapse, they will have a worsening in their condition. They will not be able to take care of the pregnancy. They will not be able to take care of the child because Freud and Erickson and lot of them has taught us what is the benefit, what is the importance of good mothering in the initial few years of the life. That is something which I think I'm trying to connect all the dots here. And if there are any take home points from everyone, I would really like to hear. Dr. Shashi ma'am, please, if you have some take home points.
The first and most important thing which I would like to say is that right from all childbearing age group women, they should be sensitized right from the beginning, because if you catch them then, whether they have mental health problems or they do not have, and then they are not how to go about. Suppose a lady is planning pregnancy, That is that time when she should be taught things and how she should take care. If she has a mental health, suppose she's having an illness, she should be advised that when she's stable, it is during that time that she should plan pregnancy. She should come in advance for consultation so that her medication can be, adjusted accordingly. So I think sensitization of the women in all childbearing age, not waiting for her to get pregnant during pregnancy, then having problems, would be a very great thing which I would like to really impart. That's very important, according to me.
Yes.
Thank you, ma'am. Dr. Kathy, ma'am, take home point from you.
Yeah, I would say that the mental health of the pregnant woman is very, very important. Now you maintain that, stabilize that in whatever way, medications, therapy, social support, mental health support from her family and everything, do whatever, but keeping the mental health stable is of utmost importance because of all the things like what we discussed, like if she's in depression, what all things can happen.
Thank you, ma'am. Dr. Sonal, ma'am, take home points from.
Basically, they have already covered most of the thing. One point which I would like to highlight is there is a constant fear of disfigurement among the ladies who are planning pregnancy. So what they do is that unknowingly they shift to some ketogenic diets and which there are millions of diets which they follow just before planning the pregnancy. Understood? So which leads to gradual osteoporosis in them, and they suddenly come to us landing ki we want to actually start. So my point is they are already calcium and vitamin B12 and all depleted. So no, better to check their levels of that also, because subsequently this hypothyroidism, vitamin B12, D deficiency and all folic acid deficiency itself can lead to depression in already the lady who's prone to depression. So please screen that all, advise them not to do any fake diets. Yeah, so and have a nutritious diet which lead to a healthy baby also.
Thank you. Ma'am, Rukshita, ma'am, take home points from you. Ma'am, mute. Ma'am, you are muted.
It takes a village to raise a child, and it also takes a village to support a woman. So it's the multidisciplinary approach where from the family to the obstetricians to the pediatricians and the psychiatrists and mental health professionals, how they work in liaison is going to really ultimately benefit the women of this country, the children of this country, and taking care of women is part of citizenry.
Right.
Very true. Thank you so much. Handing over the session to the Lupin team.
Thank you, Samiksha.
Thank you so much to everyone. It was one of the most wonderful session that I would say. Here we have come to an end of this wonderful discussion on the use of psychotropic in pregnancy and breastfeeding. I would like to thanks Dr. Rukshita for your
Thank you,
enriching
Rukshita.
and for your enriching
Wonderful.
slides as well as your
Very nice.
interactive slides. Thank you so much for making it one of the most memorable, and you put it very, very nicely and creatively. I also would like to thank our panelists, Dr. Dr. Shashi ma'am, Dr. Anita ma'am, Dr. Elsie ma'am, Dr. Sonal ma'am, Dr. Kathy, and Dr. Pratma ma'am for adding it to the core and making it one of the most contributing and enriching to our audience. So thank you so much, every panelist of this session. It will be wrong at my end, but if I miss our the moderator name, Dr. Samiksha ma'am. Thank you so much, Samiksha ma'am, for making this discussion lively and putting it through in the most creative way. I mean, starting from the beginning to end, it was, we can intact our audience. It's, as you put it, very nicely and creatively. So thank you so much, ma'am. Not without that, in the end, I also would like to thank our listeners. Without you, our discussion would have been incomplete.
Absolutely.
And thank you so much for making it
Absolutely.
more meaningful As we can see, we have almost 150 plus live audience who are listening to us. So once again, I would like to thank our panelists, our listeners, and once again, happy International Women's Day to each and everybody who is on this platform. Last
Thank you
but
so
not
much,
least,
sir.
our Lupin CNS team, medical, marketing, our sales team, everybody who have contributed and making this event successful. And lastly, the team Imagica. Thank you so much. So thank you everyone once again. And I take this pleasure to conclude and to end this session. So thank you so much once again. I would request Amitabh sir if he's there, or Suman sir if they are there on the platform.
Thank you, Dr. Manisha, for all the help,
Thank you.
for
Thank you.
all the articles and the help with the questions. Thank you.
Right.
Thank
Thank
you.
you, Manisha.
So with
Yeah,
this,
Dr.
we are
Magica,
Thank
we
you,
can.
Doctor.
Sir, just give me a 10 second to cut down the stream.
that's right.